Sorry for the technical details, but today I will talk about epilepsy imaging and what techniques we use and some common pathologies in epilepsy imaging. So I have no disclosures, and let's begin by defining what epilepsy is. So epilepsy is a medical disorder marked by recurrent unprovoked seizures. And how do we define what a seizure is? A seizure is an abnormal discharge of the brain parenchyma, resulting in a temporary disturbance of any sensory function or motor function, mental function. And the lifetime likelihood of someone experiencing a seizure is actually close to 9%. So 1 in 10 persons will actually have a seizure during the lifetime. But the definition of epilepsy is a bit more narrow. It's recurrent unprovoked seizures. So not everyone who has a seizure episode will eventually be diagnosed with epilepsy. Only 1/3 of them actually will have epilepsy, and the number of people affected by epilepsy worldwide is said to be 3%. Also, epilepsy is the fourth most common non-traumatic neurological disorder. So, what is the etiology of new onset seizures? The etiology of new onset seizures depends a bit again on age group. In adults, the most common cause we typically see is trauma. Many patients come with head trauma and they actually have a stroke, or they actually have a seizure. And after trauma, other cause of seizures are stroke, brain tumors, and metabolic abnormalities. In children, the causes are slightly different. It can be from any meningitis or encephalitis, so brain infection, congenital brain anomalies, and metabolic anomalies. So our focus today, which will be more likely on pathology, which are more likely to cause epilepsy, not seizures. We won't be talking about evaluation of seizures, but more about what are the conditions which are likely to cause epilepsy. And it is important to remember that epilepsy is again divided into generalized and focal, which we will define in the next slide. But our focus will be mainly on focal epilepsy. So again, epilepsy types is generalized and focal. And generalized, when you actually do an EEG, the electrical activity is not confined to one portion of the cerebral hemisphere. The activity actually arises diffusely throughout in bilateral cerebral hemispheres. And in such circumstances, even when we do an MRI, the yield of identifying an abnormality is actually very low. Now, that is in contrast to focal epilepsy, in which the epileptiform discharges actually arise from a focal area in the brain. And one of the most common subtype in focal epilepsy is temporal lobe epilepsy, where the seizure focus actually arises in the temporal lobe. And the yield of MRI is actually highest in this subtype of focal epilepsy, which is called temporal lobe epilepsy. So what is our imaging protocol or evaluation? So initially, when patients come into the ER, we actually do a non-contrast head CT. For imaging evaluation of seizures in the acute setting is CT, a non-contrast CT, to look for anything like a space-occupying lesion or intracranial hemorrhage. Now, MR, which is the main game changer for epilepsy management and diagnosis, typically requires a seizure-free period. And we prefer to do our patients with epilepsy on 3 Tesla, just because of the better contrast to noise ratio, the better resolution provided. And we employ thin section T1 MP range 1 millimeter images, and this sequence is excellent for cortical abnormalities. Other thin section slices we use are a coronal thin section 2 millimeter flare and T2, which should include the entire brain. So just not limiting them to the temporal lobe. Even now, sometimes our technologists send us thin section images, but they do cut off or exclude portions of the parietal lobe, and that's not acceptable. You should actually have them give you images of the entire brain. Now, the whole role of contrast typically contrast is optional. And we do get contrast images, but that's not really the most important sequence I'm actually looking at to make diagnosis. Now, if patients actually have a neurocutaneous syndrome of phacomatous, then contrast is definitely useful, but otherwise contrast is optional. Now, there are other imaging modalities which you can employ. We actually do a lot of intrarectal FDG PETs, and you can do an ictal SPECT or an intrarectal FDG PET, and you can also do arterial spin labeling perfusion MRI. So these are some other techniques used to identify the seizure focus: PET, SPECT, and perfusion MRI. So now I'm just going to show you a this is some utility of 3 Tesla over 1.5 Tesla. And these 2 images are not my images. I just kind of borrowed them. But I was just trying to show a 1.5 Tesla T2. And over here on my right is a 3 Tesla T1. And this patient's T2 image looks normal, but on the 3 Tesla, you can actually see that there are areas of gray matter in the white matter. So this is a heterotopia. This is a subcortical band heterotopia. And notice how you can actually see it on the 3 Tesla T1, but you fail to identify it on a 1.5 Tesla. I just wanted to show you the 7 Tesla over here. We have actually a 7 Tesla magnet in our facility, and you can actually see the detailed resolution of the hippocampi on the 7 Tesla. It's seen very clearly the hippocampal signals. So this is the 7 Tesla magnet, and the more high resolution you provide, the better, the more high strength magnet you do the MRI on, the more detailed cortical structure get. Now, before I proceed, I want to know which, are you able to see the mouse on this screen or the mouse on this screen? Are you able to see the mouse right now?
Yeah, we are able to see the mouse, yes.
Okay. I just wonder which, so, okay, then I'll project my mouse on this screen then.
On the right, yeah.
Okay. Thank you. So now, so focal epilepsy in young adults and children, the most common cause is temporal lobe epilepsy, and this is the subgroup where imaging has highest yield. And other cause of the main cause of temporal lobe epilepsy are hippocampal sclerosis, which we'll discuss, dysplastic cortex or developmental malformations, tumors, vascular malformations, encephalocele, phacomatous, and inborn errors of metabolism. So these are some causes of focal epilepsy, and we will review in the next few slides examples of each of them. So hippocampal sclerosis actually is the most common cause of temporal lobe epilepsy. And I have a coronal T2 and a coronal flare. And this patient actually has hippocampal sclerosis on the right side. And if you can notice, that's the left hippocampus, and the sclerosed hippocampus on T2 is actually smaller and has brighter signal. And I've not actually shown you at T1, but on T1, if you need to do T1 MP range, you can actually see loss of architecture and its atrophied appearance. So hippocampal sclerosis is the most common cause of temporal lobe epilepsy. And 95% of cases are identified on MRI. So if a patient actually has hippocampal sclerosis, it's very, very, very likely that you will actually see that on MRI. But I always tell my residents, hippocampal sclerosis is not always seen in isolation. So if you do find hippocampal sclerosis, you need to keep on looking for other abnormalities, especially there's a high association of hippocampal sclerosis with dysplastic cortex. So it's always called the satisfaction of search. You keep on looking for other abnormalities. Now, I do want to talk, briefly mention incomplete hippocampal inversion. It's less well recognized, and I also want to point out that it may not be the cause of patients' seizures or epilepsy, but it's mainly seen on the left side. Most cases of incomplete hippocampal inversion are on the left side. So what is hippocampal inversion? Normally, the hippocampus during embryology or during development actually rotates and makes infoldings. And if that infolding or rotation of the hippocampus is incomplete, it's called incomplete hippocampal rotation or incomplete hippocampal inversion. So the way you identify that is normally the hippocampus, so the normal right hippocampus is oriented in a left-right direction, or the long axis is transverse and the hippocampal sulcus is also transversely oriented. In incomplete hippocampal inversion, the hippocampus is more in a vertical direction. It's in a more vertical direction, and you can actually see how it starts horizontally but then goes vertically. So that's an abnormal morphology seen on the left side. And I want everyone to remember that when you see this in isolation, it may not be the cause of seizure. This could be an incidental finding. Usually, this finding is associated with other causes of epilepsy, other neocortical abnormalities or other cortical abnormalities. So if this is the only isolated abnormality you see on MRI and you do not see any other abnormality, it's important to recommend another imaging such as an FDG PET or perfusion MRI, because there may be another abnormality which we are not unable to pick up. So I just wanted to throw this graph, because this graph is very, very important to understand when we talk about cortical abnormalities, because cortical abnormalities, we all know that there is a germinal matrix in embryo, and the germinal matrix is closely opposed to the ventricular margin. The germinal matrix, as the embryo progresses, as the fetus progresses, the germinal matrix migrates to the, eventually the germinal matrix migrates and forms the cortex. So during this process, whenever there is an abnormality, that can result in like a cortical abnormalities or cortical abnormalities. And one such is from abnormal migration, and that results in heterotopia. So the cortex can be arrested in the periventricular region or somewhere in the subcortical region. So it can cause a periventricular heterotopia or a subcortical heterotopia. But the second scenario is the cortex successfully migrates, but it fails to organize. When I say organize, we know that the cortex contains 6 layers. So the normal neocortex contains 6 layers, but if they fail to form those 6 layers, let's say they form only 4 layers, and there's a lot of balloon cells, or they actually form dysplastic cells which are not mature enough, and they fail to lamellate exactly or properly, it forms a dysplastic cortex or polymicrogyria. And dysplastic cortex and polymicrogyria can look very, very similar on MRI. There are only subtle differences. In dysplastic cortex, you actually have less lamination and you actually have vacuolated cells. In polymicrogyria, you just have supernumerary gyri. And this distinction is mainly seen on pathology. It's sometimes very difficult to make that distinction on imaging. And then the cells migrate, they properly organize, but then they proliferate, and that causes hematomas and cortical tumors. So that's the pathogenesis of cortical maldevelopmental disorders. So if we look at this particular example, this patient actually has cortical thickening around the cilium fissure. And you can actually see that finding on both FLAIR and on coronal T1 that there is actually some cortical thickening around the Sylvian fissure. This patient also has an absent corpus callosum. Now, whenever you see cortical thickening around the Sylvian fissure, think of polymicrogyria. So polymicrogyria is most commonly perisylvian. That's actually one subtype. But whenever you see cortical thickening, you want to think of polymicrogyria, which is supernumerary gyri. This patient also actually has band heterotropia also. If you notice, there's also some heterotropic gray matter. So these malformations of cortical development occur, sometimes they don't occur in isolation. You have one or two or three simultaneous abnormalities. So this is a band heterotropia. So, this patient's seizures were actually, this patient actually presented with a left temporal lobe seizures, and you can actually see that this patient actually has abnormal migration of the cortex, both polymicrogyria and heterotropia. Now, we will talk a bit about dysplastic cortex because this is the most challenging one to diagnose. It's also underdiagnosed and undertreated. So it's a major problem in epilepsy imaging. I'm going to show you this axial T2. Doesn't really look terribly abnormal. The same patient's coronal T2, all you can see is that there's some blurring of the gray-white matter in the left frontal lobe. So notice how you see that the gray-white matter junction is blurred. There's some hyperintensity in the underlying white matter. And that's all you can make out in dysplastic cortex. So I'm actually just showing a graph. This is not the same patient's brain biopsy, but this is just, I just borrowed this image from the internet. And this is how dysplastic cortex looks. So this is the normal cortex, but a dysplastic cortex, the cortex is thickened, can have a slightly abnormal signal, which extends into the underlying white matter. Now, you have to remember that dysplastic cortex, there are various types. So type 1, type 2, type 3, and each one has a distinctive pathological abnormality, but we're not going to go into types of each dysplastic cortex. But I'm going to actually focus on the general overview of common findings in dysplastic cortex. So this is how it can look like. And this patient actually had a dysplastic cortex in the left frontal lobe. So it is abnormal lamination with enlarged giant neurons, and it's a thickened cortex, and with blurring of the gray-white matter junction. Just relax. These are my residents in the reading room after a tiring day. They have this resident lounge, and they're just relaxing. So, and now we will want to focus on the alternative imaging in patients. So you have an axial T2, which looks normal. So I want to again stress that if the MR is normal, you need to consider other imaging. And this patient actually, this was an arterial spin labeling perfusion MRI, which was done in our children's hospital. And if you notice, there is reduced perfusion in the left frontal lobe. And this patient actually was taken off for surgery, and he had dysplastic cortex in the left frontal lobe. So there's reduced perfusion in the area on arterial spin labeled perfusion MRI. Arterial spin labeled perfusion MRI is a non-contrast MR technique. We don't actually give contrast. It's a non-contrast MR technique, which is used in many centers to diagnose areas of epileptogenic foci. The epileptogenic foci will show decreased perfusion, and that's how you identify the area of dysplastic cortex. Now we have another patient who also had an MRI which was negative, but this patient underwent a FDG PET, and notice that there is actually reduced uptake in the medial left frontal lobe, and this patient also had a dysplastic cortex of the right frontal lobe. There was an area of reduced uptake in the right frontal lobe, and this patient was diagnosed with dysplastic cortex in the right frontal lobe. So again, to reiterate, if MR is negative, arterial spleen labeling MRI and PET are more sensitive for identifying subtle cortical abnormalities, which are seen in dysplastic cortex. So again, focusing on multiple developmental anomalies. So this patient actually had a PET and MRI on the same day. You can see this periventricular heterotopia, which on the MRI, this area of gray matter just adjacent to the atrium of the right lateral ventricle, and that lights up. Normal gray matter lights up. In heterotopia, the area of abnormally located gray matter can exhibit similar activity to the normal cortex. So it's not hypermetabolic, unlike dysplastic cortex, where that cortex is really hypofunctioning. In heterotopia, the cortex may be normally functioning. So you can actually see this island of gray matter, or not an island, but this area of gray matter in the periventricular area, which lights up on PET. Now, this patient actually also has mesial temporal sclerosis. Again, as we discussed, when we actually have mesial temporal sclerosis on MRI, most of our residents, when they actually read an MRI for temporal lobe epilepsy, they pick up the mesial temporal sclerosis because that's the most common finding. He does have a mesial temporal sclerosis on the same side, but again, as emphasized, when you actually have mesial temporal sclerosis, you need to look for another abnormality. And in this patient also had heterotopia. And if you notice, there is reduced activity in patients with mesial temporal sclerosis. The affected hippocampus shows reduced activity. So again, these are all very important because remember that cortical abnormalities can undergo surgical resection. But if you actually have an abnormality in the deeper brain, unfortunately, they can't undergo surgical resection. It's very difficult to undergo surgical resection. So there are other forms of you can do like a laser treatment or something like that to ablate that epileptogenic focus. So now I'm just going to show you a 30-year-old female with seizures, and the diagnosis is obviously schizencephaly. So that's another disorder where you see a CSF cleft connecting the overlying CSF with the ventricles, and the gray matter which lies the schizencephalic cleft is abnormal, and it's polymicrogyria. So this is polymicrogyria, and this is schizencephaly. So remember that the cause of seizures in schizencephaly is the polymicrogyria. So it's not the cleft, but the abnormal gray matter which lines the cleft, which is polymicrogyric. So schizencephaly with polymicrogyria. Now, I do want to talk about stereo and electroencephalographic leads. Now, this is probably a last resort. Now, you've done multiple imaging. You've done an EEG, which fails to recognize or the EEG is kind of equivocal. And when all imaging is negative, including maybe your PET, your ASL, then these patients undergo invasive leads placement. And these leads are placed in deep portions of the brain. So remember that EEG leads EEG leads pick up seizures from the superficial brain, but sometimes if the seizures are arising from the deeper portion of the brain, you have to do something invasive. And this electroencephalography actually determined that there was abnormal seizure focus in the anterior temporal lobe. And this patient eventually underwent a right temporal lobectomy, and they actually found dysplastic cortex over there. So this is a very invasive investigation and is done as a last resort when every imaging fails to demonstrate the epileptogenic focus. Now we'll focus on epilepsy, but another subcategory of pathology, which is tumors. So here I have two different patients. One has an abnormality in the right parietal lobe, which is kind of cystic and doesn't really enhance very well on post-contrast MRI. And the other patient actually has an area of expansile lesion in the anteromedial left frontal lobe. So these are two different tumors. So the one on my left side is a DNET, which is a common developmental cortical tumor, and they have a very good prognosis because they don't really grow very quickly. They expand slowly. But these tumors, which are called as cortical tumors, their main presentation is from seizure with epilepsy. They don't cause mass effect. They don't cause headache. They don't cause raised ICP, but they actually cause seizures because of their cortical origin. And it's important to identify them because they fail to respond to anti-epileptic medications, and those patients probably warrant a lesionectomy or seizure focus removal. It's very, very important to remember that patients who fail treatment with anti-epileptic drugs will be considered for surgery because it improves their quality of life. It significantly improves their quality of life. And the moment you see this, okay, if this patient actually has seizures, then this patient will get a surgical resection. And this was a ganglioglioma, another well-defined tumor which involves the temporal lobe. There's a lot of similarity in all these neocortical tumors. They commonly arise in the temporal lobe. They commonly are solid and cystic, and they actually have minimal enhancement. So trying to differentiate a DNET from ganglioglioma may be sometimes difficult, but the most important thing is to recognize them as tumors. The very famous soap bubble appearance is actually typical of DNET. So now it's just not low-grade brain tumors which can cause epilepsy. I have, again, two different patients. In the patient on my left, I have this flare signal change in the insular cortex and the right temporal lobe, extending into the right thalamus, which doesn't really enhance. And then on my right side, I have this very expansive lesion in the left hippocampus, which enhances. So these are two different tumors. Again, this was a low-grade astrocytoma, and this was a GBM. A low-grade astrocytoma is different from a cortical tumor. A low-grade astrocytomas are infiltrative. For example, when I say infiltrative, they actually infiltrate the underlying white matter, and they actually spread. And in this case, it has spread to the basal ganglia. A cortical tumor such as ganglioglioma or DNET does not go to the basal ganglia. So the fact that this is a non-enhancing tumor which has spread to the basal ganglia makes me think of an tumor like an astrocytoma or a glioma, that subcategory of tumors. And we think of GBM as a solid and cystic necrotic tumor with vasogenic edema, but I see so many atypical infiltrative GBMs which show very little enhancement. For example, this GBM actually shows some enhancement. I've seen many GBMs which actually never enhanced. So GBM has all spectrum of abnormalities, and both of these patients actually present with long-standing epilepsy. So it's important to think of just not neocortical or cortical tumors, but also more aggressive astrocytomas and GBMs in the etiology of epilepsy. So now we will talk about phacomatosis. So this is a patient with epilepsy, 26-year-old, and he has multiple foci of dysplastic cortex with flare signal changes. And notice there is, these are all multiple areas of dysplastic cortex. So dysplastic cortex is, if you look at solitary dysplastic cortex or isolated dysplastic cortex, they're actually focal in one portion of the cerebral hemisphere. But when you actually have multiple dysplastic cortices, that's typical of tuberous sclerosis. The cortical tubers or cortical hamartomas are areas of dysplastic cortex. So they are very similar in pathology, and they typically don't enhance. And these cortical tubers have areas of flare signal change extend into the underlying white matter, but have no mass effect or no enhancement. And sometimes you can also see radial bands in tuberous sclerosis. So this is a radial band which extends from the cortex to the white matter. So this patient had tuberous sclerosis. So tuberous sclerosis is one of the most common neurocutaneous syndrome which presents with epilepsy. So you always want to give contrast in these patients because these patients could have subependymal giant cell astrocytomas which enhance. So it's incomplete if you evaluate these patients without contrast. And then never forget encephalocele. So this patient actually had left temporal lobe epilepsy, and there's this gliotic encephalocelic or encephalocele, which is extending from the temporal lobe into the mastoid air cells. And that's another cause of temporal lobe epilepsy. So always never forget temporal lobe encephalocele. And this is actually a very gross case, but I've seen more subtle cases. And these are especially common in patients with idiopathic intracranial hypertension. So especially in young women in 30 to 40, they present with seizures. I try to look for any underlying encephalocele because they can present with CSF leak, but they also can present with seizures. So this was actually this temporal lobe encephalocele was resected, and this patient actually had a skull base repair. And lastly, this patient actually had recent seizures, and there was actually diffusion restriction in the overlying cortex with some edema. So what could this be? Could this be a low-grade cortical tumor, or could this be a dysplastic cortex? So you want to remember that low-grade cortical tumors or dysplastic cortex actually do not restrict diffusion. So that restricted diffusion means that, oh, it can't be a low-grade cortical tumor, it can't be dysplastic cortex. So it could be encephalitis. So encephalitis is definitely in our consideration because encephalitis can restrict diffusion and present with edematous cortex. But we did a follow-up MRI after 3 weeks, and this signal change actually disappeared both on DWI and flare. So this is reversible cytotoxic edema of in seizures. So it's called transient cytotoxic edema and seen after status epilepticus. So that's the reason why when we look for seizures, we'll do it during a seizure-free period most often. We want a seizure-free period because if they actually had a recent seizure, that can cause transient cytotoxic edema, which can interfere with our ability to identify seizures. So, but this is actually seen in patients in status epilepticus, and it's cytotoxic edema. It can be actually multiple. It can be present in multiple cortical areas, but it says it prefers the hippocampus and thalamus, but I've seen it in multiple cortical areas, including the basal ganglia. And sometimes there is even mild enhancement. It's important to be aware of this finding whenever there is diffusion restriction and whenever there is multiple areas involved, and to actually have a follow-up MRI within 3 or 4 weeks, and these changes resolve, and then we know that's not actually a cortical abnormality. So in conclusion of seizures, it's important to know the etiology of seizures, important, and depending on the age group, important to exclude cortical abnormalities, and in younger adults and with children with focal epilepsy. And remember that when you actually have an epilepsy in a younger adult or a child, the epilepsy protocol, which should include whole brain thin section images, reveals the highest yield in patients with epilepsy. And it's important to remember that if these patients should preferably be scanned on a 3 Tesla magnet, and if that is negative, it's important to recommend a perfusion MRI or a FDG PET. We most commonly do an FDG PET. We actually do an FDG PET and MRI on the same day, and that's for logistics. We do a PET MRI, and that's the highest yield. We don't really like patients to come back if the MR is negative. Also, MR can only measure one abnormality, and it may show hippocampal sclerosis, but FDG PET can actually show other abnormalities. So we do a PET MRI on the same day. And if that is not negative, if that is negative, then we probably proceed to a stereo electroencephalogram to look for a epilepsy focus or a seizure focus. So thanks for your attention. Now I'll leave this for questions.
Thank you, Dr. Siddharth. Can you hear me? I am Dr. Jagan.
Yeah, yes, I can hear you, sir. I can hear you, sir.
Thank you for your nice lecture, and you have given all the examples of epilepsy and seizure, and you have given the protocol also. My question is, like, we used to struggle a lot. Actually, you are also there. Evaluate the temporal lobe sclerosis, what we call mesial temporal sclerosis. We were calculating the volume and doing a 3D scan and sometimes spectroscopy like that. Now, what exactly are you calculating? In those days, it was a manual calculation. That way, there was a lot of struggle. Now, of course, the calculation of volume is much easier. But you have not mentioned about that volume calculation. And the second question related to this is, suppose instead of recalling the patient that MRI is normal again call them and do arterial spin labeling. Can we add arterial spin labeling in the same setting as a part of epilepsy protocol?
So the second question you asked is actually much more easy for me to answer. So we don't do arterial spin labeling on the day of the MR because of the insurance. Here in US, it's mainly insurance will not cover it unless there's a specific reason for arterial spin labeling MRI. And if we start doing arterial spin labeling MRI at the time of MRI, even though even though we're not actually, it's an extra sequence, the way billing is, insurance doesn't cover for that study. So even though it's a non-contrast study, so we actually have to get the patient back, and that's unfortunate. And in our experience as adult radiologists is our protocol in Children's Hospital, they do arterial spin labeling MRI. We are not doing arterial spin, we are actually doing it very few. We actually rely on our Children's Hospital cases to do arterial spin labeling MRI, but our protocol is always to go for MRI and PET on the same day. And if we don't actually see an abnormality, we actually don't do the arterial spin labeling MRI in most circumstances. We go directly for electrode implantment. That has been our protocol, but we cannot do arterial spin labeling MRI unless it's insurance, unfortunately, will not cover that for adult patients. Now, coming to volumetry, again, I remember doing volumetry in India, but we aren't, for some reason, I never thought about it, but we actually do not do hippocampal volumetry in our places. And even in other centers, I've not seen them talk about hippocampal volumetry, but so I do not really have much experience here in terms of trying to identify subtle case of hippocampal sclerosis with volumetry, because we are not actually doing that here. Are they doing it in India? Are they doing it as a routine, hippocampal volumetry?
We were doing, not nowadays, but I just want to know what is the new protocols.
So if you look at all the protocols from at least the ACR protocols in most institutes, it's not a norm. It's not a required. Maybe some centers are doing it, but most of the time the reliance is on coronal thin section, T1 weighted images done on a 3 Tesla MRI. Because when we're identifying hippocampal sclerosis, we are actually looking at abnormal morphology. If you're looking for the lack of clear architecture within the hippocampus, you're looking for abnormal signal. So these are all the abnormalities you're looking for. So there are many other abnormalities you're looking for apart from decreased size. That is also, and it is also well described that in patients who have had long-standing temporal lobe seizures, regardless of the origin of the seizures, whether it's in the hippocampus or not, the hippocampus undergoes secondary atrophy. So the atrophy of the hippocampus may not be the cause of seizures in many patients who have hippocampal atrophy. It may be actually just secondary to long-standing seizures. So when you actually have an isolated hippocampal atrophy without any corresponding T2 flare signal changes, sometimes that could just be a sequelae of long-standing seizures. So that's also very important to take into consideration.
Thank you, Dr. Siddharth. One more question is related to, when we look at the CT, there will be a small calcification in the cortex or around the subcortical region. Now, those patients will be having seizure of epilepsy, and MRI will be normal, that even the calcification we may not pick up. So in those cases, can we interpret that the cause of epilepsy is due to calcification, or is there any other studies to prove that?
So so there's some geographic in India and other countries, we see a lot of these calcifications. So most of if I have to take a step back here, neurocysticercosis is actually the most common cause of seizures and epilepsy worldwide. And I did not mention this actually because these statistics I'm showing are actually from here in unfortunately, I'm showing the US statistics. But yeah, you're right. If the patient actually has if the patient actually has multifocal calcification in the cortex and subcortical white matter, it's most often due to a granulomatous disease such as TB or neurocysticercosis. And if the MR is actually normal, and if the MR doesn't, the MR and the PET don't actually show any other cortical abnormality, yes, that is the most likely cause of patient's epilepsy, probably the granulomatous disease. And if they have multiple, then it's you cannot resect them. But if there's a single focus of calcification, that probably could be considered for seizure surgery. But here we don't actually see cortical calcifications from granulomas very often. Most often we see cortical calcifications from a treated tumor or from remote trauma, but our incidence of seeing cortical calcifications is actually very low over here.
Thank you, Dr. Siddhartha. I open for discussion. Anyone like to comment?
Dr. Siddharth, this is Dr. Kishore LT speaking.
Hey, hello, Kishore. How are you?
Good, I'm fine. It's always nice to see our students from NIMS doing wonderful work throughout the world. So we feel so proud about it.
Thank you, sir.
Right. So I just want you to make one comment that in our daily day-to-day MRI reporting, which is done due to some other cause, not because of epilepsy, we do see some amount of hippocampal atrophy. Okay, patient doesn't have epilepsy, he has come for something else, but if you see carefully, there will be some amount of hippocampal atrophy. You have any comments to make about that, about how common it is and whether these patients eventually will develop epilepsy or whether they had epilepsy in past? Would you like to make a comment on that, please?
Yeah, I'll try it. So to make a diagnosis of hippocampal atrophy, we rely on our thin section coronal images, and our routine protocol for our routine MR brain protocol for indications other than epilepsy doesn't actually include thin section coronal T1. Only if you're doing for dementia, we do thin section coronal T1. But if you're doing it for any other reason, such as brain tumors or headache, we don't actually do thin section coronal T1. So it's very, very difficult to actually make a note of the hippocampal atrophy on non-epilepsy or non-dementia protocol MRIs. Now, let's say if I were to make that diagnosis in a young adult, I probably would look up in the patient's history if the patient was also diagnosed with seizures, and if there is no history of seizures, and I'm just saying it out of the question because you asked this question, and I've not actually experienced this situation myself because of we don't actually do dedicated coronal images or thin section coronal images in patients apart from epilepsy. So if I were to actually see a patient who just gets it for some other reason, I would say atrophy of the left hippocampus correlate for history of prior seizures. I would just say that, but I don't know. I don't have enough knowledge to know if these patients who are identified incidentally actually would develop seizures later on. Typically, patients with hippocampal sclerosis develop seizures from the first decade to third decade. Developing seizures from hippocampal sclerosis from fourth decade is actually very, very rare, even if they actually had it. So it's if you actually see a 55-year-old with hippocampal sclerosis and has had no history of prior epilepsy seizures, then they probably they probably don't have they probably had incidental hippocampal sclerosis, which was never manifest clinically.
Yeah. Okay. My second question is when we see, say, for example, you showed one example of heterotopia and mesial temporal sclerosis. So when you have these multiple lesions, how do we decide which is exactly the focus of epilepsy and where a surgeon should operate? How do you go about that?
Yeah, so that again, I forgot to actually, that's a very complicated topic. So typically they actually go for SEEG. These patients go for a preoperative SEEG lead placement, and they actually, that SEEG lead placement will decide which is the surgical site of epileptic focus which has to be removed, because no surgeon wants to do extensive epileptiform surgery, because if the more and more brain tissue you take out, the more and more disability the patient can arise. So that's another reason for doing an SEEG lead placement is when you have multiple abnormalities, then they place a intraoperative SEEG to identify which is actually the epileptogenic site.
Now, are you telling that your surgeon will always do SEEG before every surgery of epilepsy?
For most surgeries, they do it.
Okay, I see. Interesting. And then you showed one case of tuberous sclerosis, and I saw that the diploid spaces were looking grossly abnormal. What was that? Yeah.
Now let me go back to it.
Yeah.
Oh, you're talking about this one? Yeah. So this patient actually has some marrow expansion. So I'm assuming maybe I don't know. I don't know if this patient was shunted. Sometimes these patients develop hydrocephalus, and if they have shunting, as a response to shunting, they can actually develop expansion marrow. I don't see a shunt here though, but no, I don't know the exact reason why. But that's a good observation. I'm assuming it's from prior shunting.
All right. Thank you, Siddharth.
Thank you, Siddharth. Any other comments, questions? From the chat box, you have a good compliment. Excellent talk, very useful to radiologist residents and practicing radiologists. Good job, Siddharth. Any other questions and comments?
As an extension of volumetry, you also used to do T2 relaxometry of the middle temporal lobe. Has it got any role today? Relaxometry.
No, we don't actually have employed that. It's not in our protocol. So maybe under research, but in clinical practice, no, we don't actually do that. No.
Okay, if there are no other questions, then we can conclude the session. Over to Dr. Ishwar.
Thank you, Siddharth, from Krest and Hyderabad, for again coming and giving a wonderful presentation on a very common topic. Each time we learn new things whenever we talk about epilepsy. Thank you so much. I look forward to more lectures and interaction in the future. We'll meet next month. I'll post the flyer soon. Again, it will be on December 14th and December 28th from Krest. Thanks to Jagan sir and Dr. L.T. Kishore and all of us for joining in. See you soon next month for another interesting session on this. Thank you, Siddharth, once again.
Thank you, everyone, for inviting me to talk. It's a pleasure talking to all my teachers every time. So thanks so much, Jagan sir, for joining. And thank you, everyone. Thank you, Ishwar, Kavita, and Kishore, everyone for joining. And thank you for Dr. Power. I see you also here. So thank you for joining. And I'll meet you again sometime soon. So have a happy Saturday.
Thank you so much. Yeah.
Thank you. Bye.